What if the pill you took this morning, the one sitting right there in your weekly organizer, is silently making your heart work harder than it should? Not a dangerous drug, not a recalled medication, one of the most commonly prescribed pills in America for adults over 60. I know that sounds hard to believe. It did to me too, until I started seeing the same pattern repeat itself in patient after patient over 15 years of cardiology practice. Today, I'm going to walk you through 5 medications that deserve a second look if you're over 60, why they can stress your cardiovascular system, which warning signs your body may already be sending you, and what smarter alternatives exist that most people never hear about. Stay with me, because point number 3 surprises nearly every patient I tell it to. Here's the reality. After 60, your body processes medication differently. Your arteries are less flexible. Your kidneys filter more slowly. Your heart has a narrower margin for extra strain. A drug that worked perfectly for you at 55 may behave very differently at 70. Not because something went wrong, because biology changes and medication plans often don't keep up. By the end of this video, you'll understand exactly which drug categories deserve a conversation with your doctor, what questions to ask at your next appointment, and how small adjustments to your medication routine can meaningfully reduce your cardiovascular risk. My name is Dr. Gregory Holt. I'm a board-certified cardiologist with over 15 years of clinical experience, and I've spent the majority of my career working with adults over 60 who are managing multiple health conditions at once. I've seen what thoughtful medication management can do, and I've also seen what happens when it doesn't happen. Before we go further, everything I share in this video is purely educational. It is not a substitute for professional medical advice. Please do not start, stop, or change any medication without speaking to your doctor first. What I'm offering here is information, not instruction. Your heart deserves personalized care, and no video can replace that. Now let's get into it. Most people think of ibuprofen or naproxen as harmless. They're available at any drugstore. You've probably taken them dozens of times without a second thought. Stiff knee in the morning? Reach for the ibuprofen. Lower back flare-up? Naproxen gets you through the day. But here's what the label doesn't tell you. NSAIDs, non-steroidal anti-inflammatory drugs, don't just block pain signals. They also interfere with chemicals in your body called prostaglandins. Those chemicals do more than regulate inflammation. They help keep your blood vessels relaxed and your blood flowing smoothly. When you suppress prostaglandins, here's what can happen. Blood pressure rises, fluid starts to accumulate in your tissues, and blood platelets become stickier. For a 45-year-old with healthy arteries, the body compensates. For a 72-year-old with some arterial stiffness already in the picture, that compensation is much harder. Think of your arteries like a garden hose. At 40, the hose is flexible. It expands a little under pressure without a problem. At 70, the hose is stiffer. Add more pressure inside, and the stress on the walls becomes significant. I had a patient, I'll call him Robert, 71 years old, retired engineer, took a daily walk every morning without fail. His doctor recommended naproxen twice a day for hip arthritis. 3 months later, he came in for a routine check. Blood pressure was up 12 points. He had no idea. He felt fine, but his heart was working measurably harder every single day. We didn't panic. We adjusted. Switched to a topical anti-inflammatory gel, added physical therapy, modified his diet slightly. Blood pressure came back down within 6 weeks. The lesson? Daily, long-term NSAID use in adults over 60 deserves regular reassessment. The lowest effective dose for the shortest possible time. That's the principle. If you're currently taking an NSAID every single day, add this to your list of questions for your next doctor's visit. Don't stop on your own. Just start the conversation. Sleep gets harder as we get older. You know that. I know that. And when a doctor offers a prescription for a sleep aid, it feels like relief. Benzodiazepines like diazepam or Z-drugs like zolpidem are commonly prescribed. And yes, they help people fall asleep. But here's the part that rarely gets explained. These medications work by depressing the central nervous system. They slow things down, including the part of your nervous system that regulates heart rate, blood pressure, and vascular tone overnight. In older adults, this is where things get complicated. Your autonomic nervous system, the system that quietly manages your heart rate and circulation while you sleep, is already more sensitive after 60. When you add a sedative that suppresses its function, a few things can happen. Blood pressure may drop too much during the night. Breathing can become irregular. Heart rhythm can be affected. And if you get up to use the bathroom, which most people over 60 do, the sudden drop in blood pressure upon standing can cause dizziness, confusion, or a fall. A fall at 74 isn't like a fall at 34. It can mean a fractured hip, a hospital stay, weeks of reduced mobility, and a cascade of health consequences that follow. I want you to picture Margaret. She's 76, sharp as a tack, volunteers at her local library twice a week. After her husband passed, she started having trouble sleeping. Her doctor prescribed a sleep medication. Within a month, she was groggy every morning. One night she got up, felt the room tilt, and grabbed the door frame just in time. She told me about it almost as an afterthought. I told her it was not a small thing. We worked together on sleep hygiene, cooler room, no screens after 9 p.m., a consistent bedtime, magnesium glycinate under supervision. She sleeps better now, without the medication, and without the risk. Cognitive behavioral therapy for insomnia, CBTI, has actually shown better long-term results than sleep medications in clinical trials. It's not as quick, but it's far safer. If you've been on a sleep medication for more than a few months, that's worth discussing. Stay with me, because point number 3 catches almost everyone off guard. You've got a cold. Sinuses are blocked. You can't breathe through your nose. So you walk into the pharmacy and grab a decongestant. It's right there on the shelf. Pseudoephedrine, phenylephrine, familiar names, low price, easy. Here's the problem. Decongestants work by constricting blood vessels. That's the mechanism. It reduces swelling in nasal passages, but it doesn't only constrict vessels in your nose. It constricts blood vessels throughout your entire body. Blood pressure rises. Heart rate increases. For someone with stiff arteries or any degree of plaque buildup, even undiagnosed, that spike is not trivial. I've had patients with beautifully controlled blood pressure, stable for years on their medication, come in after a bad week of cold medication use, and their numbers looked like they'd stopped treatment entirely. They were shocked. So were their spouses. But it's just a cold pill, one man told me. I've taken it my whole life. That's exactly the trap. The cardiovascular system doesn't read the label. It doesn't know that pill came from the cold and flu aisle, not the pharmacy counter. It only knows blood pressure just spiked. For adults over 65, especially those with high blood pressure, heart disease, or arterial stiffness, systemic decongestants deserve real caution. The alternatives are boring, I know. Saline nasal rinse, steam inhalation, humidifier, elevating your head when you sleep, antihistamines that don't raise blood pressure. But boring is safe, and safe matters more as we get older. If you're watching this and currently have decongestants in your medicine cabinet, check the label, and on your next doctor's visit, ask specifically, given my cardiovascular profile, which cold remedies are safe for me. This one surprises people more than almost any other. Proton pump inhibitors, you probably know them as omeprazole, pantoprazole, or by brand names like Prilosec or Nexium, are among the most commonly prescribed drugs in the world. They're effective at reducing stomach acid. For people with chronic reflux, esophageal damage, or ulcers, they can be genuinely necessary. But here's what the long-term picture looks like. Some research suggests that extended PPI use may interfere with nitric oxide production, a molecule your blood vessels rely on to stay relaxed and flexible. Less nitric oxide means less vascular flexibility. Less flexibility means more cardiovascular strain. There's also a documented connection between long-term PPI use and magnesium depletion. And low magnesium isn't just a nutrition issue. Low magnesium can trigger irregular heart rhythms, arrhythmias, that in an older heart can have serious consequences. Again, this doesn't mean PPIs are wrong for everyone. For the right patient, they're an important treatment. But if you have been taking one daily for 5, 8, 10 years, originally prescribed as a short-term fix for occasional heartburn, it may be worth asking, do I still need this? At this dose? Think of it like this. You borrowed an umbrella because it looked like rain. It worked great, but now it's been sunny for 3 years, and the umbrella is still in your hand. At some point, you stop and ask, do I still need this? Lifestyle changes like reducing portion sizes at dinner, avoiding eating within 2 hours of bedtime, losing a modest amount of weight, and elevating the head of the bed have helped many of my patients significantly reduce, and in some cases eliminate, their need for daily acid medication. The heart connection matters, and it's one most people taking these medications have never heard. This last point is critical, and it's one where the good news is just as important as the concern. Diabetes significantly increases the risk of heart attack and stroke. That's well established. So controlling blood sugar is non-negotiable. But here's what many patients don't know. Not all diabetes medications have the same cardiovascular profile. Some older generation diabetes drugs were found to promote fluid retention or increase the risk of heart failure in certain patients. And while newer medications have dramatically improved the picture, some actually reduce cardiovascular risk, not just blood sugar. Those benefits only reach you if your medication regimen has been updated to reflect current evidence. Many patients I see are still on the same diabetes medication they were prescribed 12, 15 years ago. The medication works for blood sugar. Their numbers look fine on paper. But the cardiovascular risk landscape has shifted significantly, and their treatment plan hasn't kept pace. Think about a road that got repaved, with new lanes added and better signage. But you're still following a map from 2009. You'll get somewhere, but maybe not the safest route. I'm not suggesting you change anything today. I am suggesting you have a specific conversation with your doctor. Given what we now know about cardiovascular outcomes and diabetes treatment, is my current medication the best choice for my heart as well as my blood sugar? That question alone can open a door that changes your trajectory. Here's something I need you to understand before we wrap up, because it explains why so many people are surprised when cardiovascular problems occur. The average adult over 65 takes between 4 and 8 prescription medications daily. Each one may be appropriate on its own, but together, they create an environment of layered cardiovascular stress that no single prescription was designed to manage. One medication raises blood pressure slightly, another causes mild fluid retention, a third mildly affects kidney clearance, a fourth alters heart rate regulation at night. On paper, each drug is doing its job. Together, they're creating a slow, cumulative strain. This is polypharmacy, and it's one of the most under-recognized cardiovascular risk factors in older adults. The solution isn't to eliminate medications, it's to ensure someone is looking at the full picture. That someone, more often than not, needs to be you. You are the only person who sees every doctor, fills every prescription, and takes every pill. You are the central coordinator of your own health. No specialist sees the whole puzzle unless you bring it to them. You don't need a medical degree to do this. You need a piece of paper, 20 minutes, and a willingness to ask better questions. Step 1. Gather every medication you take. Prescription drugs, over-the-counter medications, supplements. Put them all in one place. Step 2. For each one, write down what it's for, how long you've been taking it, and who prescribed it. Step 3. For each one, ask, does this raise blood pressure? Does it cause fluid retention? Does it increase clotting or bleeding risk? Does it affect heart rhythm? Is it still necessary? Step 4. Monitor your blood pressure for 7 consecutive days, morning and evening, and write down the numbers. Look for patterns. Does it rise on certain days? After certain medications? Step 5. Bring this information to your next appointment. Not just for a refill, for a review. That's the difference between managing your medications and being managed by them. Let's run through what we covered today. NSAIDs can raise blood pressure and promote fluid retention. Daily long-term use deserves reassessment after 60 sleep medications can disrupt autonomic regulation, increase fall risk, and affect nighttime cardiovascular function. Decongestants constrict blood vessels system-wide, not just in the nose, posing real risk for anyone with arterial stiffness or hypertension. Proton pump inhibitors used long-term may reduce vascular flexibility and deplete magnesium. Certain diabetes medications vary significantly in their cardiovascular profile. Your regimen may need updating. And underlying all of it, polypharmacy creates cumulative effects that no individual prescription was designed to account for. I want to leave you with something that one of my longtime patients said to me after we reviewed his medications together and made a few adjustments. He said, "I didn't know I was carrying all that weight. Now I feel like I put it down." He wasn't describing dramatic drug side effects. He was describing the quiet, invisible strain that had been accumulating for years, strain that neither he nor his doctors had paused to add up as a whole. Your heart beats over 100,000 times a day. It never clocks out. It never takes a day off. The very least we can do is make sure we're not adding unnecessary weight to its workload. You have more agency here than you may realize. A single conversation with your doctor, armed with the right questions, can change the direction of your cardiovascular health in a very meaningful way. Prevention at 65 is easier than recovery at 75, every time. If this video gave you something useful, something worth sharing, send it to a friend or a family member who might benefit. And if you want to keep learning how to protect your health after 60, subscribing takes 1 second and make sure you don't miss what's coming next. In the next video, I'll be covering something that surprises almost every patient I share it with. A single vitamin that research suggests may actually reverse nerve damage in adults over 60 in as little as 14 days. If you or someone you love deals with tingling, numbness, or nerve pain, that is one you cannot afford to skip. That one is not to be missed. Take care of yourself, and take care of that heart. This is Dr. Gregory Holt. I'll see you in the next video.